Good morning and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. Before we get started with the speaker introduction, a few housekeeping issues. These Grand Rounds will be broadcasted through live stream and YouTube. The recording is always available for viewing afterwards. You can consider subscribing to the YouTube channel to follow our Grand Rounds. And if you have questions, you can submit the question texting DeBakey to the number 37607. You may also submit the questions via a live streamed feed. In the DeBakey Education program, we also have coming up two conferences: pre-inter training for vascular residents in June 5 through 7, and cardiology for the non-cardiologist in June 17. Moving on to our speaker today, it is an honor and a pleasure to have Dr. Paul Friedman from Mayo give us a lecture today. He is the Edward and Betty Knight Scripps Professor in Cardiovascular Medicine in Mayo. He's the chairman of the Department of Cardiovascular Medicine. Paul ended up in Mayo after training in UT, where he graduated as an electrical engineer here in Austin, and then moved on to Stanford, where he did his medical school training, followed that by training in Mayo Clinic as a cardiologist, as well as a cardiac electrophysiologist. His contributions in clinical EP are huge. He has covered from the mechanistic contributions in particularly atrial flutter, lower loop reentry, and other mechanistic studies in clinical EP, to procedural aspects, to spanning from catheter ablation to device management as well. He is a prolific inventor. He has more than 40 patents and has taken ideas from the patent to even commercialization, and has started several companies. He is also a leader and a very approachable person. He's a super nice guy that I consider a friend. You can run cases by him and discuss, mentoring issues and other things. So he's really a very powerful figure in the field. Lately, he has been devoting his efforts in artificial intelligence and basically unearthing a new field in clinical electrophysiology that has implications not just for EP, but also for general cardiology and the application of the delivery of healthcare to the population in general. So we are honored to have Paul and very eager to hear your lecture. Paul?
Miguel, my friend, thank you. I think only my mother could have done a nicer introduction. That was very warm, thank you. And it's a great pleasure to be with you and your colleagues. I'm just disappointed I can't be there in person. I look forward to when that can happen. I thought I would start just with this image on the slide, and I'll ask, and since I'm not in person, think in your own minds, who painted that picture? Now, this is a cardiology conference, not an art conference, but I put this up for a specific reason. If you answered Dali, you'd be correct if you spelled it the right way, which is D-A-L-L-E. This is a generative AI where you type in, and at the time I was giving a talk actually in Jerusalem at Hadassah Hospital, where they have Chagall windows. And I said, show me a painting in the style of Chagall of a cardiologist taking care of a patient with atrial fibrillation. And here you can see this remarkable figure. And it's just one of the many ways AI is doing so many remarkable things. Of course, when one colleague saw it, the question was, how many fingers do cardiologists have? But here are my disclosure slides as they relate to this talk. And I'm going to start here. In the 1600s, in 1672 specifically, when a Parisian shoemaker walks into the street and dies suddenly, as recorded by Bonitus in his Sepulchritum, in his section De Morte Repentina, or of sudden death. And it turns out that he, sorry, I just have a slide issue here. Give me a second. It turns out that they found aortic valves of bone. And I put this up, and I'll come back to this specific case because it really gets to the core of what we're trying to do. And that is to help address that primordial question that humanity has asked in time immemorial: what's going to happen to me? Can I predict it? Can I do something about it? And when you think about medical care, quite commonly what happens is someone is living his or her life and they feel great, when suddenly, like a bolt of lightning, signs and symptoms develop, and only then do we start doing diagnostic testing and treatment. But all of us recognize there's a fundamental problem with that approach, especially in cardiovascular medicine, because the first event may be a stroke, heart attack, sudden cardiac death. But all of us recognize that those metabolic and physiologic derangements, that atherosclerotic plaque, has been present for at least a decade before the initial event. And if we can learn to read the invisible signals our bodies are giving off all the time, we could then prevent that cataclysmic, catastrophic event from happening. And that's the goal of this work. Now, we started with asymptomatic left ventricular dysfunction, a weak heart pump, because it impacts 2% of the global population, 7 million people just in these United States, 9% of people over the age of 60. And what's terribly important is we all recognize there are multiple treatments that prevent death, prevent hospitalization, prevent bad things from happening to people. ACE inhibitors, beta blockers, SGLT2 inhibitors, cardiac resynchronization devices, defibrillators. But the trick, of course, is to identify left ventricular dysfunction. And even in resource-rich environments, it can mean being away from work for 2 hours, being face-to-face with a sonographer, getting an expensive test such as an echocardiogram, CT scan, or MRI scan. But all of us recognize that if you place a microelectrode into a single cardiomyocyte, we get this action potential, this change in voltage over time, which is controlled by ion channels, sodium channels, potassium channels, chloride channels that are so critical to life, they've minimally evolved from bacteria to humans. If you stop and think about it, every thought in your head right now, every move you make and every breath you take is controlled by these currents. And it turns out that these currents are impacted by disease often before we can see changes in an MRI scan or a CT scan or an echocardiogram, so that diseases can be detected when otherwise seemingly occult or early. And if we aggregate millions of these, we get the surface recording, the electrocardiogram, which is ubiquitous, inexpensive, integrated into medical workflows, available from South Africa to South Korea and from South America to Europe. And so what we did was we took advantage of this robust digital warehouse of medical data, and we utilized a convolutional neural network, a form of artificial intelligence, where it's designed to mimic human cortex. Only instead of individual neurons, there are simple math equations, which, like neurons, once there are sufficient inputs, they generate a threshold output. And the key point is you would first put in an electrocardiogram, the voltage time waveform, and ask the network, what's the ejection fraction? And it would have no idea. And it would guess, it would say 35%. And during training, we would say, no, it's actually 55%. And through a process of back propagation, it starts adjusting the weights and biases in each of these neurons to slowly get the network closer and closer to creating a function that if you give it an ECG, it can give you the answer. And the key point, as I started to say, is that to initially train the network, it takes a lot of data and a lot of computing power. But once it's trained, you have a math equation you can run on a smartphone. And in fact, we then tested it, and we measure the performance of a test with the receiver operating characteristic. And as you're aware, a treadmill test has a 0.85, as does a mammogram. A pap smear is a 0.7. This test, the computer's ability to read an ECG and say, is left ventricular dysfunction present, was 0.93. So a very powerful medical test. What was more striking was when it seemed to get it wrong. So we'd feed an ECG into the computer. It would say weak heart pump. Echocardiogram says, no, it's normal. That person for 6 years and they have a 5-fold increased risk of developing a weak heart pump. Seems like magic, like it's predicting the future. But we recognize what's happening is that those ion channels are being affected by disease. Multiple small nonlinear changes are happening on the surface ECG. Because if you sort of reflect on this, in order for us to see a typical finding, say ST segment elevation in a myocardial infarction, you have to have millions of cardiomyocytes affected in a similar manner to change the pattern. But many disease states result in smaller, nonlinear, potentially changes in unnamed segments. but by being able to predict disease, we could perhaps define a high-risk cohort. Now, up to this point, we were only feeding in the voltage time waveform of the ECG, but we know heart disease is a function of age and sex. So we thought, what if we give that computer the additional information? Will it work even better? Will it help? And the answer was no. We thought, how can that be? How is it possible? And then we thought maybe from reading the ECG, the computer already knows the age and sex of the person whose ECG it is. So we asked it, and here's what we found. The ability to determine sex, as shown on the right, has an AUC of 0.97. It is almost perfect. In other words, the computer reading an ECG is better able to determine someone's sex than I am walking down the street looking at that person. It's really a very, very powerful test. And really interesting was this concept of ECG estimated age. On the x-axis is the chronologic age in years. On the y-axis is the ECG calculated age, which we've come to learn is biological age or vascular age or physiologic age. And we see that although there's a strong relationship, some people are 40, but they look like they're 65, and some people are 60 and they look like they're 40. And we've all seen this in our clinic, right? The 60-year-old who's coming in and looks like 40 is someone who watches what he or she eats, exercises regularly. The 40-year-old who looks like they're 60 is the person with diabetes, hypertension, multiple infarcts. So I thought I'd show some cases to make it real. Here's one of my favorites, a classic one. Here's a man who at age 38 looks like he's 55. And as time goes on, he's getting older by ECG age until something remarkable happens. At age 53, he starts getting young. And when I've asked the audiences, what do you think happened? I get an array of intriguing answers. They range from he went on a diet, he started exercise. I had one man say he got divorced. I had another man say he got married. So, but what actually happened was he got a heart transplant. He literally got the heart of a 16-year-old. His blood pressure starts to go down, his weight goes down, his diabetes resolves, and as you can see, his physiologic age gets younger. Here's another case, a 35-year-old woman who presented to the CV Prevention Clinic for a plan of intentional weight loss. She weighed, at the time, 106 kilograms, and her AI-ECG age was 40.8 years, although she was 35. And we use this concept of age gap, that is the physiologic age minus the chronologic age, as a measure of your overall physiologic age, wellness, fitness. And she managed to very successfully lose weight. And so at roughly half a year later, she lost 10 kilograms and her AI-ECG age dropped so that her age gap went from 6 years to 0 years. And we have seen that a number of conditions are associated with physiologic and biological age. And in fact, my colleague Barry Boylston did a study looking at senescence of cardiomyocytes in the setting of heart failure, where there were a number of biological markers of advanced aging, including telomere length, as well as other protein activations, and found that these were correlated and associated with AI-ECG age. And indeed, deep learning-derived cardiovascular age is associated with clinical as well as cellular and molecular markers of senescence. And we've seen in a number of studies that social isolation, like during the pandemic, makes you physiologically older. Acute illness makes you older, getting younger upon its recovery. We talked about obesity. If you look at population studies, Russians are older than Norwegians based on vascular aging correlated with population-based mortality and morbidity. Coronary microvascular disease is associated with aging, and particularly interesting is progeria, lamin AC deficiency. Not surprisingly, in this condition, people are 10 to 15 years older than their chronologic age and sadly tend to die young. Now, here's a different case, changing gears. A 35-year-old asymptomatic man presents after his sister dies tragically, unexpectedly, suddenly. Take a look at a minute at the ECG of our patient, this man, and what do you think it looks like? The computer, the standard CART computer, called it normal. Artificial intelligence was run, and it said left ventricular dysfunction is present. An echocardiogram said ejection fraction 18%. Turns out that there was a familial dilated cardiomyopathy, and you think, My gosh, what if his sister had had this test before her tragic event? Here's another case. AI ECG is positive for low EF. Echocardiogram, EF is 50%, false positive. 5 years later, age 33, the echo now is 31%. And it gets to this concept that because these changes are happening in the ion channels likely earlier than we can see them on imaging, we detect disease earlier by this means. We have this new concept of pre-disease, or this concept of AI disease pre-vivors. What if you know you're going to get a disease? Can we prevent it? What does it do to your psyche? What does it do to your insurance? There are a slew of societal, personal, and medical questions that this type of technology raises. Now, because it's software-based, it moved quickly. We initially published it in January of 2019. 12 months later, FDA gave it breakthrough technology designation. 5 months later, emergency use authorization during COVID, and it's now in the final stages of a formal FDA approval. Now, the key question, of course, is can this modify clinical practice? Because the goal would be someone's in clinic, you get an electrocardiogram, AI analysis is run for, say, left ventricular dysfunction, you're notified in the EHR, and then an echocardiogram is done to drive evidence-based therapy to reduce death and prevent bad things from happening to people. But there's a missing component in this slide, and that missing component is us. Do we believe it? Are there financial structures that let us order the echo? Is there access for the echo? To address these questions, we did a clinical study. The goal was to determine whether an AI screening tool could in fact detect low ejection fraction in practice. And so here's what we did. And this was done during the pandemic, but because it was software-based, we very rapidly deployed it, and we enrolled over 22,000 people in 8 months. And the way we did it was we randomized primary care teams in Minnesota and Wisconsin so that the clinicians were randomly assigned to intervention arm whenever they ordered an ECG based on their clinical practice, that is standardly indicated ECGs, they would get an additional piece of information. It would say AI was run on this ECG and ventricular dysfunction was identified, or it would say AI was run on this ECG and no ventricular dysfunction was identified. And what we found when we did that it was effective. In the control arm, it was run in the background, but we didn't tell clinicians what it showed. And what we found was that when you gave clinicians this information, a new diagnosis from people who did not previously know they had ventricular dysfunction was increased by 32% compared to the control arm. The AUC of the test, when we ran it prospectively in the wild, matched that of the retrospective analysis, 0.92. Importantly, resources were well allocated because it turned out that the group with the AI ECG guidance ordered the same number of echocardiograms as the control group, but the yield was higher. They picked the right people to order the echocardiograms on so that this expensive and limited resource was better utilized. And importantly and interestingly, it really supported the so-called top of license care. That is, the clinicians who most frequently follow the recommendations were nurse practitioners and physician's assistants, and they were twice as likely to diagnose a low EF as the internist and family practitioners. However, it's important to recognize that there were sicker and more complex patients on the internist and family practitioners panels, and that may have impacted who should have had that sort of diagnostic evaluation. But importantly, none of the people who participated in the execution of this trial, none of the clinicians were cardiologists, none were AI specialists, again, showing how this tool can be used in a busy clinical work stream. Now, the next question is, well, if we can do this in the clinic, can we do it at home? Can we do it from a watch? Think about how massively scalable that would be. Think about the patient getting chemotherapy and you're wondering about whether left ventricular dysfunction is happening. Think about the patient getting mavacamten for hypertrophic cardiomyopathy. I mean, think about anyone, high-risk individuals. So we used an Apple Watch, and Apple had no role in the study. We only told them about it after we completed it. But Apple did something a year and a half ago that was important for us, and that was they enabled anyone to access the ECG from a watch recording in their health kit. But an Apple Watch ECG is not identical to a 12-lead. Here's a 12-lead ECG from a patient with a pacemaker. You can see spikes. And here you can see the Apple Watch ECG with filtering, it's gone. So we had to retrain our model, so-called transfer learning. That is, imagine you know how to read in English, but you only know how to read block letters and someone hands you something in cursive. Well, because you already know how to read English, it wouldn't take long to learn the cursive component, but someone would have to tell you, well, this is what an A looks like or an I looks like and so on. And that's what we did for the AI. And we created an app with the Mayo Center for Digital Health. And that app, essentially, we enrolled people with an email. We'd say, are you interested in this study? These were people who had been seen at some time in their lives at Mayo Clinic or had downloaded the Mayo Clinic app. So they'd get an email, are you interested? If they said yes, they would do a consent form via DocuSign and then download this app. And by this means, over 5 months with one part-time study coordinator, we enrolled 2,500 patients from 46 states and 11 countries and obtained 125,000 ECGs, completely exploding the physics, the time and space of a clinical trial. We didn't have to wait for someone to walk into the office and say, do you want to be in a study? And patients knew their data would go to a dashboard, but we didn't do anything with it unless they called us. But this dashboard, and I'll talk more about this, was available in our EMR, and it's incredibly helpful. And then we could run AI on this data. And here's an example of this dashboard use. This was from one of my patients. She was telling me she felt fine. And then on this date, all of a sudden she said, yeah, it didn't feel right. And she did an ECG. The Apple Watch says atrial fibrillation. I can look at the actual tracing and I can blow it up and review it and make management plans accordingly. And we had patients ages 18 to 94 involved. They stayed engaged throughout the study, maybe because they knew their data would become available to clinicians. But it's important, as opposed to a consumer approach. We had high engagement throughout the study. And interestingly, I should say, older individuals were more likely to stay engaged than younger people. And here's what we found. I mentioned how rapidly and effectively we could acquire data. When we ran the ECGs to see whether we could identify left ventricular dysfunction in those individuals who also had clinically ordered echocardiograms, this test was very powerful. Not quite as powerful as a 12-lead, but still very powerful. But think about it. A 12-lead ECG is done in a medical environment where you lay down, your skin is prepped, a technician is present telling you to hold still. An Apple Watch, and I'm sure many of you have Apple Watches, as you may know, you may be slouching on the sofa after dinner and say, I wonder what my ECG is doing. And so think about the noise, body position, all that, and nonetheless, it still worked well. An important issue is healthcare equity, because you can say the watch is expensive. Well, we disadvantage people without the resources. Although, a promising hope would be that because the watch is relatively inexpensive compared to, say, an ECG machine or an echocardiogram, we could put it in resource constrained environments and let anyone who comes in just put on a watch and get a screen. And then those individuals could be more appropriately selected for additional testing. Now, I want to take a few minutes to talk about a different topic, and that is atrial fibrillation. Atrial fibrillation fills our professional society meetings. If you go to Heart Rhythm Society or AHA or ACC, there'll be discussion about how do we ablate it? Do we use cold? Do we use heat? Do we use alcohol? But the vast majority of atrial fibrillation is actually subclinical, asymptomatic, underdetected, and associated with stroke. And you've asked many of our patients, they'd rather die than have a debilitating stroke. And I suspect many of us feel the same way. And so I thought I'd share this case with you. Here's a patient, a 92-year-old woman who has multiple risk factors and comes in with a left frontal stroke. You can see her ECG here. And the question is, and just think in your own mind, would you observe, treat with aspirin, or treat with apixaban? Now, as you can see, the ECG shows normal sinus rhythm. There was no evidence of atrial fibrillation, and I'll come back to her case in just a minute. But the challenge, of course, is that the management fundamentally depends on whether or not atrial fibrillation, but it's often asymptomatic and fleeting. And in my own sort of simple approach to stroke is there are two broad mechanisms. There are those that are left atrial appendage independent, that is arterial, atherosclerosis of the arch, the carotid, the intracerebral vessels. And there's a rich body of neurologic literature that we use aspirin or antiplatelet agents, because if you anticoagulate these patients, as very recently shown, for example, by the Navigate ESA study, Bad things happen. People get CNS bleeds. They die. You're not improving their outcomes. But conversely, if atrial fibrillation is present, if you have a left atrial appendage dependent, a venous mechanism, then we know that warfarin or oral anticoagulants prevent recurrent stroke and may lower mortality. So the treatment depends on whether or not atrial fibrillation is present, but atrial fibrillation is intermittent and hard to detect. So we'll often implant a loop recorder and hope that we detect recurrent atrial fibrillation if it's present before a stroke happens. But what if from a sinus rhythm ECG, you could tell that someone had atrial fibrillation yesterday or will have it tomorrow? Can AI tell us about silent atrial fibrillation? So what we did was we took two cohorts of patients. One, on the top here, as best as we could tell, never had any evidence of atrial fibrillation recorded, documented in the chart in any way. And we fed those into the computer, those ECGs, as this is an ECG from someone with no atrial fibrillation. And then another cohort with episodic atrial fibrillation, we fed in ECGs into the computer, but we never showed the computer actual atrial fibrillation. We would give it a sinus rhythm ECG from a time adjacent to the atrial fibrillation and say, this is a sinus rhythm ECG from someone who has atrial fibrillation at other times. Can you tell the difference? And the answer was yes. The area under the curve for identifying this was 0.9, and we've since sort of modified it, tweaked it, made it even slightly stronger. And if you think about what that means an ECG acquired over 10 seconds becomes a Holter monitor. And we don't know the duration of it, but it tells us that at other periods of time, there may be atrial fibrillation. And so for this patient, coming back to our case, because there was only sinus rhythm at the time, she was treated with aspirin per guidelines, per evidence base. 5 years later, she has another stroke, still in sinus rhythm. Thrombus was seen in the left atrial appendage, and anticoagulation was started. And then a week later, she gets an ECG and it confirms atrial fibrillation. And you think, gosh, could we have detected this sooner? So we looked at all of her ECGs, and on the x-axis, you see the year, and on the y-axis, you see the AI output for probability of silent atrial fibrillation, and red dots exceed the threshold for the test and are considered positive. Here was her first stroke. Here was her second stroke. For a 10-year time interval, she was having silent, under-detected atrial fibrillation. What if we had done more intensive monitoring? What if we had started anticoagulation? And the question is, what's inside of this AI black box? And I've looked at a lot of these ECGs, and it is impossible for me to tell. And I'll just show you. Here's a specimen from a cadaver showing right atrium, left atrial appendage. And I've superimposed tracings from an EP study. Here you can see atrial fibrillation and on the surface. And note that in real time, in the coronary sinus, we get what looks like an electrogram, an isoelectric interval, an electrogram, what we would call flutter. And at the same time, in the septum, we have this continuous fractionated signal that's consistent with atrial fibrillation, showing that there's heterogeneity in the substrate. And maybe that's what it's seeing, that there are these subtle changes in the ECG, and that if we could learn the patterns from hundreds of thousands of ECGs ourselves, then we would see it. And so there is this concept. When you think about the risk factors for atrial fibrillation, they're all associated with inflammation, heart failure, hypertension, diabetes, sleep apnea, vascular disease. Here's one paper for diabetes. And when we think about the heart rhythm, in normal sinus rhythm, we think of like a pebble in a pond and this propagation of an electrical signal, but we know that requires intact and functioning ion channels, gap junctions, an intact architecture and a homeostasis to make this happen. And on the surface ECG, in this situation, we would say it's normal sinus rhythm, and AI would say there's no silent atrial fibrillation. But now imagine that inflammation starts to disrupt part of the architecture, and the presence of lymphocytes and tumor necrosis factor and interleukins results in disruption of the architecture of the gap junctions and of the function. We'd start to see ripples in the stream, and the ECG would still show sinus rhythm, but now maybe the AI ECG would say silent atrial fibrillation might be present, or at some point when this was enough, because we recognize if the scar burden gets big enough, then the atria will simply fibrillate. And at that point, you don't need the ECG because you have the ECG showing you atrial fibrillation. Now, these cartoons are pleasant to look at, but is there evidence to show that this happens? The answer is yes. I could talk about this for an hour, but I promise I won't. But I'll just show you a few key slides. This one was fascinating, done in Italy in 1997, where they took biopsies of patients who had WPW and no atrial fibrillation and compared them to biopsies of 12 patients with lone atrial fibrillation. And to confirm that it was lone atrial fibrillation, all patients had an echocardiogram, coronary angiography, hormonal and virologic studies. And here's what they found. Here's one patient with 20 episodes of AF a day. Here's the ventricle, which is fully normal. Look at the number of interstitial debris. Look at the vacuolization of the nuclei and the architectural disruption. It's not hard to imagine that signals would not propagate normally in this kind of architecture. Here's another patient who actually had so many lymphocytes infiltrating in the atria that it met the Dallas criteria. And interestingly, these criteria were present in 66% of the patients met the Dallas criteria for myocarditis, but only 5% had ventricular abnormalities. We all know that statins, among their pleiotropic effects, reduce inflammation. And in this study by Patty et al., they found that if you take patients without a history of atrial fibrillation, no statin therapy, and pre-treat before bypass surgery, the atrial fibrillation-free survival was significantly increased. Hospitalization was reduced, again, showing this relationship between inflammation and atrial fibrillation. And this is one of, I think, the most fascinating observations. This has been repeated by several other investigators, and this work done by Emil Dowd. He took patients who had pacemakers and a stroke. The red line shows the date of the stroke. These bars indicate when monitoring was happening, and the black lines indicate when atrial fibrillation was present. And if you look at these for a minute, you'll make a really important observation. And that is, the vast majority of patients who had a stroke did not have atrial fibrillation, atrial tachycardia, or high rate episodes, as we call them in pacemakers, in the month before the event. And you say, how does that happen? How is it possible? Because the classic thinking has been atrial fibrillation leads to diminished contraction, left atrial appendage thrombus, and then a stroke, which would mean that atrial fibrillation would have to precede the stroke event. But what if there's vascular inflammation and fibrosis and an atrial and vascular myopathy, and atrial fibrillation becomes a marker of the disease burden? Then there'd be no temporal association between the fibrillation and stroke. One more study, and then I'll put this part all together. And this was work done by Barry Borlaug, one of my colleagues, where he did both echocardiographic, as shown here, with left atrial volume index, left atrial reservoir studies of patients to see if the AI-enabled ECG screen for AF was in fact associated with a left atrial myopathy. And irrespective of whether you looked at echo parameters or cath lab parameters that I didn't show, there was a strong association. And of course, the development of new onset atrial fibrillation in patients without a history was highly correlated by the AI probability, as was freedom from all-cause mortality, showing that the novel AI-enabled score might be identifying this left atrial myopathy as the mechanism in patients with HFpEF, who are the ones who were included in this study. And so perhaps atrial fibrillation is a marker of fibrosis and inflammation and vascular disease, and perhaps the AI-ECG is a marker for the marker, an earlier detector. And if we consider this paradigm, then there's health, which could progress, especially in the presence of risk factors, to pre-atrial fibrillation, which can flip your AI-ECG positive. And as inflammation and fibrosis progress and as vascular health declines, then clinical atrial fibrillation may develop and ultimately a stroke. So we have retrospective data showing that it works. We have biological plausibility, but the question is, does AI work for AF screening in practice? And to answer that, we did a clinical trial. And here's what we did. We looked at the stored data from patients who had been seen at Mayo in the past 2 years and had stored digital ECGs and screened them for silent atrial fibrillation. In other words, we screened over 600,000 patients in nanoseconds. Again, the new physics of a clinical trial. They don't have to show up and come to our clinic. And if AI said silent atrial fibrillation was present, we then ran a different kind of AI called natural language processing to say, would you treat? Or in other words, what was the CHADS-VASc score? What was the HAS-BLED score? And if the CHADS-VASc score was 3 for men or 2 for women, and they were anticoagulation candidates, we enrolled them in a study and we sent them a monitor to wear for a month. Now you might say, why 1,000 patients and why a monitor for a month? Well, budget. At the end of the day, these are the parts of the trial that get really expensive. I would have loved to monitor everybody for a year or longer. And of course, we now look at enrollment in geographical maps, and you can see, of course, they were dispersed. And I'll share with you one of the first patients we enrolled. This was a retired Mayo Clinic physician, one of our colleagues. He'd come to us every year, and we'd say, you're fine, control your blood pressure. And we plotted his ECGs over time, and you can see for the last at least 10 years, he was having silent atrial fibrillation. He gets the email note, enrolls in the study, gets the monitor, and within the first week, atrial fibrillation is recorded. He gets a consult. He's put on anticoagulation. Maybe this is what stroke prevention looks like. Why wait for the first stroke? Here's another case. This was a different retired Mayo Clinic executive. He shared his story with Casey Ross from STAT, the Boston Journal, and he'd had a stroke and was not anticoagulated, enrolled in the study, and atrial fibrillation was similarly found. And it's a very thoughtful piece. It talks about the potential risks of anxiety and stress, as well as the benefits. So I'd encourage you to read it if you'd like more of a sort of in the non-medical, but very human description of how this technology can impact lives. This is what the trial found, essentially, that within a month, we found in the high-risk group arrhythmia in just under 10% of patients, so very high yield. And it's true whether you're looking at 30 seconds, 6 minutes, or 24 hours of atrial fibrillation. The odds ratio was 5. So in other words, it was more effective at identifying high-risk individuals than usual care in a matched control group. And certainly low-risk individuals had a very low incidence of atrial fibrillation. I want to underscore that all the patients enrolled would already be considered high risk using the CHARGE-AF score. So we're not cherry-picking patients and applying this. We're taking a cohort of patients who already have multiple risk factors. And this may be, for example, why the LOOP study didn't quite reach statistical significance. You can't just take an age cutoff and say, okay, you're at risk. We may have to do more, and perhaps this is the more that may help us get there. But clearly, we found patients at high risk based on the AICG were more likely to have AF diagnosed than those followed with usual care, and that this may be a powerful screening tool. Interestingly, by the way, the next question, and the more pressing one may be, what about the risk of stroke? And when we looked at patients who had brain imaging, if your AIECG AF score was high, you were more likely to have had an infarct. And by the way, you're more likely over time to develop a decline in cognition heading towards dementia. So can we treat today based on an AI positive ECG? Well, the answer is we don't know. I will say anecdotally, it's been performed in high-risk cases. And one of our colleagues recently had a stroke, presented, had a positive AI ECG, but normal sinus rhythm. And my colleague treating him started him on anticoagulation, which of course made me very anxious. But he then, a few days later, actually had atrial fibrillation recorded. And of course, he, our colleague who had the event now, is a huge fan of this approach. But the best current evidence is if the IECG is positive, intensely monitor. I think in a very high-risk individual, if you wanted to start anticoagulation and begin monitoring, I would say you're outside of the evidence base, but there's clinical judgment always in what we do. I thought I would share one more case. And this is a 67-year-old man who presented with progressive dyspnea and actually congestive heart failure. And he lives just a few miles from Mayo Clinic, from our facility. And here's what's interesting. I'm coming back to the initial slide that I presented, because as you might imagine, there are a lot of conditions that the IECG can screen for, aortic stenosis being a great example. And it turns out that he had 8 years earlier an ECG, and you can see it here. And we ran an AI algorithm designed to screen for aortic stenosis, and it was negative. 3 years before he presented with overt heart failure and shortness of breath, it was positive. And it's this repeated cycle we see of it identifies diseases before we become aware of them. It identifies occult disease as well as impending disease. Here's another example for amyloid heart disease, previously a death sentence. Now, of course, we all know there are a number of new therapies available. And here's a patient where the AI-ECG detected it 2 years before the diagnosis. Liver disease, another example. The so-called ACE score, or the AI-ECG, performed well to identify cirrhosis. It's not surprising. We've known forever that liver disease impacts the ECG through repolarization changes, and in later stages, hemodynamic sequelae impacting the RV function. And you can see the AI-ECG score matches the MELD sodium score, and then it goes up until time of transplant, and then it goes down. So there are a number of different AI-ECG tests that have been developed or in various stages of development, and they consistently find occult disease, and they can predict disease. And importantly, there are new effective therapies for a number of these. So the question is, how do we make this available in clinical practice? Well, for about 1.5 years, 2 years actually at Mayo Clinic, we've embedded it into our EMR. So when we see a patient, we click on this button, AI-ECG dashboard, and we get this dashboard. And it's spread by word of mouth and been used without any formal notification over 500,000 times, in part because it's just an easy way to review ECGs. This is a still slide, it's not dynamic, but you could click on any of these ECGs and it'll pull up the actual tracing for review. You can zoom in and overlay ECGs to compare them. And the AI is plotted here. In this patient, normal EF, no HOCM, silent atrial fibrillation, and so on. So in summary, the AI-ECG effectively identifies occult disease and predicts impending disease. It's massively scalable. It will be transforming medicine. And we are working to move it to hospitals outside of Mayo Clinic and always looking for colleagues to collaborate with. And with that, I will stop and thank you for your attention.
So, Paul, that was amazing. I'm clapping here. Very, very exciting. I wanted to go deeper on the atrial fibrillation because you made a very strong case for the AI algorithm to detect silent AFib. But a problem that the consultant electrophysiologist faces many times is the weaknesses of the CHA2DS2-VASc score. So you have a patient with diagnosed AFib. There's nothing silent about it. You just have a pacemaker with a few episodes of AFib, or even someone with permanent AFib. And we all have patients that within the spectrum of AFib and CHA2DS2-VASc scores, they are outliers. I have a patient with 10 years of AFib. She refused anticoagulation. She bled. I think she developed angioid vasculopathy in the brain. No anticoagulation, not even aspirin, never had a stroke. She only had trouble when they gave her blood thinners. Can AI tease out within already the diagnosis of AFib add value to the CHA2DS2-VASc score? Because it's extremely frustrating.
Yeah. The answer is potentially yes, but that work is still in its infancy. We've done a little bit of work. I showed one slide looking at this question of can we predict who's going to have stroke? Because obviously that's what we really care about, especially if I say that atrial fibrillation can also cause heart failure, can cause symptoms, but stroke is the most pressing one. And the short answer is maybe. That's work still to be done, still in its infancy, and we don't know. The more robust application where we have more confidence in the ability is someone who, if they had atrial fibrillation, we would treat, identifying it, and then we can confidently say, if the AI-ECG is positive, intense monitoring will have a high yield. That's what we've definitely demonstrated, but there are so many more important clinical questions that are still just being developed. So my hope is that in 1 year or 2, we'll have the answer to your question, Miguel, but we're not there yet.
How about helping the interventional electrophysiologist with ablation strategies?
Yes.
That may need perhaps more sophisticated EKG, perhaps the surface multi-lead, the vest or whatever. But it's a common problem for us that you see a patient with persistent AFib, and many times you get in there and you know all they need to do is pulmonary vein isolation and it's taken care of. And there are others where you have to burn and burn and burn, and it's an endless source of frustration. I really would like to have a tool to tell me, you know what, don't bother with this patient.
That is an area of energetic but still very early work. We started with the 12-lead ECG because we wanted something that would be massively scalable and impactful. And as you know, so much disease, whether it's heart failure, atrial fibrillation, is actually seen initially by our colleagues in primary care. And so we have really focused on identifying occult disease so that the primary care clinicians know who to refer, when to refer, and hopefully can be reassured on those that don't need referral so that cardiologists can do what cardiologists are best at, which is taking care of more complex cardiovascular disease. But we are now turning this tool inward, so to speak, and we'll hopefully be able to answer those questions. But that is still ongoing work, I would say. So we don't really have a way to do it yet. But there's no reason to think it won't work. But it's a lot of effort to label the data, clarify the data, define the problem. You know what I mean? It's an ablation procedure is a data-rich, complex environment.
So when I first heard about AI, I was actually viscerally opposed to it because to me it seemed like the abdication of understanding, and I keep trying to figure out, like you showed, what is it about the EKG that AI is seeing that I am not? And in another way to say it, can machine learning help human learning? And it seems like that's a lost battle, right? We're never going to learn anything?
I would call it an ongoing battle because I'm an optimist. And my hope is that we can actually learn more about disease by identifying what the AI is seeing in the ECG. So for example, we've taken stabs at that. It's difficult. We wanted to know, what does the AI see for ventricular dysfunction, for example? So we looked at a number of different parameters. And if you were to take just QRS width, for example, you would have an AUC of 0.7. So there's information there. It's just not the whole story. And I still think that doesn't impact the use of AI because there's certain lot of examples in medicine where we use tools we don't understand. A prime example, a contemporary one, would be SGLT2 inhibitors for congestive heart failure. How does it work? I mean, nobody knows, but we know it does work. Or you could think of a different neural network, like bomb-sniffing dogs. They're useful and they're used, but we don't know what's going on in the dog's neural network.
So one of my last question, then I will go to the audience questions. Do you see AI tools ever becoming available to us for us to ask our own questions? Right now, it seems like this is something that only select centers with select expertise like you and your center can develop. But just like ChatGPT has made coding available to ignorance like me, and you can ask the tool to write a code for you, would you ever see this available to us? We may have questions that may not be of interest to you, and we want to play with it too.
Yeah, absolutely, I do, and I think it's going to spread and diffuse fairly quickly over the next couple of years. But you have to be careful. There's this phenomenon that you're likely familiar with called ChatGPT hallucinations.
Okay.
I don't know. Have you seen it?
No. What is it?
Oh, well, I have, because I'll give you a very specific example. I was talking to a colleague last week about sub-Q ICD implantation immediately following bypass surgery, like, a day or two later. Because there's concern about, the fresh wound and whatnot. Should we do it? So I put in a ChatGPT search, and it said it's been safe, and it said it's been, in one study of 36 patients that is implanted 24 hours after surgery. It said Journal of Cardiac Electrophysiology 2019, and gave me the reference. And so I was in a hurry. I said, here's what ChatGPT thinks. And he responds back, these references don't exist. They didn't. They look real, but it completely fabricated it. They call them ChatGPT hallucinations. It's a known thing. I would call it a fabrication, or perhaps a confabulation, or perhaps an outright lie. But you have to be really careful in medicine. So I think it'll be important that a lot of us get our hands on this, that we're critical of it, that we test it. In the ECG space, it's more constrained, confined, and we don't get that same level of, I'll say distraction. But anything will have a false positive, right? But bottom line is, yes, I think it will evolve and spread, and fairly quickly.
So when you showed the examples, just clarify for me, there is an algorithm for low EF, there's an algorithm
Yes.
for hypertrophic cardiomyopathy, and I take it these will be thinking of the business model, because obviously there's a business model behind this.
Yes.
You sell the package for AS, and you sell the package for hypertrophic cardiomyopathy, or a combo deal, or how does that
I
work?
don't think so. So first, a little background, and I went over my disclosures quickly, but Mayo Clinic has formed a company together with others that is charged with making these available to patients. And so they are taking them through FDA to get regulatory approval. And they've also generated a billing code. And so it'll be like an advanced billing code on top of an ECG that will run, is how I'm envisioning it. And I think that the goal has always been to, unlike some things that with time become outdated and less useful, the goal would be to have a dashboard in any hospital where, we and others keep adding algorithms, because the world is too big and there are too many problems for one hospital to do it. And as you know, there are a limited number of hospitals right now engaged. So the goal would be to have an environment where anyone with an algorithm, once it reaches a level of approval, could add it. And hopefully there would be, the sort of growth in their use, so that they're actually touching lives and making a difference.
And one says, thank you, Dr. Freeman. I'm curious to know, for those patients with normal ECG but high CV risk based on AI, was the CV risk estimated by the ECG alone, or did it fit more clinical characteristics?
So all the work we've done that I showed today was ECG alone. And we do it that way because it's easy, fast, simple, scalable, can go to hospitals with different EMRs, can go overseas. And in fact, we are collaborating with hospitals in South Korea, South America, or Africa, I should say, Europe, Asia. The getting data out of EMRs, which is increasingly being more available, still is a barrier. And so, as you know, just to calculate a CHADS VASC in somebody, it's not automatic. It's not like our EMR anyway. It doesn't tell us what it is. We have to then, there's a so-called calculator. Well, the calculator makes me do the work. I have to go in and say, how old is the patient? Do they have hypertension? And whereas an ECG is fully automatic. And so that's why we stuck to that for now. Ease of use is critical because clinicians are so busy, right? There's no one who says I have extra time in my day to do stuff.
Another question is, do you worry at all about overfitting with machine learning? Not sure what they mean, but...
So what that means is, if you have a very specific data set and you create a model that's by running it so many times on that specific data set, that it works very well, but only on that specific cohort. It's not generalizable. And so for not all of the algorithms yet, but like for the low EF one, which is maybe the most developed, we developed it using roughly half of our sample and then tested it on the other half first. Then we tested it in multiple Mayo sites because there's some variation in terms of ethnic background of the patients there. And then we've tested it specifically to look to see if it performed well based on race and self-reported race and ethnicity, and published that. And then we've also tested it actually in other countries. So we don't think that one, has implicit bias or overfitting or other statistical or technical limitations.
Now,
but we have to prove that for all of them, because the one last comment on that. Sorry to go on, but an AI model learns from what it's taught. And so if it only tested people from Rochester, Minnesota, it could give wrong answers from people from other parts of the world, right? Because we're all different. And so we've been very mindful and careful about that.
Has anybody compared the Mayo algorithm with the one developed, I think it was in Geisinger, with similar idea to detect AFib in EKGs in sinus rhythm?
I don't think those have been detected head-to-head that I'm aware of, but it could be. There was a performance comparison in the same manuscript of an algorithm for hypertrophic cardiomyopathy, which was the UCSF algorithm and the Mayo Clinic algorithm, and we all worked together on it. And the bottom line is both work very, very well. Mathematically, there was a subtle difference between one and the other. I'll refer you to the paper, but we were pleased.
Well, this was excellent, very, very inspiring and intriguing, and I'm sure the audience will be thinking and talking about your talk for a while. Thank you for coming, even though remotely.
Thank you for having me.
Looking forward to seeing you soon.